This is a video in clinical medicine from the New England Journal of Medicine.
Thoracentesis is used diagnostically to establish the cause of a pleural effusion. It can also be performed to drain large effusions that lead to respiratory compromise. Limited data exist regarding the safety of thoracentesis in patients with coagulation abnormalities. The procedure is probably safe in patients with mild or moderate elevations of the prothrombin time or partial thromboplastin time. The decision to use fresh frozen plasma or platelet concentrates in patients with clinically significant coagulopathy or thrombocytopenia must be made on an individual basis. The procedure should be used with care in patients who are receiving mechanical ventilation, since positive pressure ventilation may bring the lung close to the thoracentesis needle and increase the risk of pneumothorax. Thoracentesis should be deferred in patients with severe hemodynamic or respiratory compromise until the underlying condition can be stabilized. In patients who have small or loculated effusions, the procedure should be performed by experienced operators, ideally with real-time imaging guidance. The thoracentesis needle should not pass through sites of cutaneous infection such as cellulitis or herpes zoster. Numerous devices, which are frequently available in prepackaged kits, can be used to perform thoracentesis. You should become familiar with the specific devices available at your institution. In this video, we will use a standard intravenous over-the-needle catheter assembly to demonstrate the procedure. For sterile preparation of the site and administration of anesthesia, you will need a skin cleansing agent, sterile gauze, sterile gloves, a sterile drape, a hemostat, which is optional, 1 or 2% lidocaine, and a 10 milliliter syringe with a 22 to 25 gauge needle. For the collection of pleural fluid, you will need an 18 to 20 gauge over-the-needle catheter, a 60 milliliter syringe, and a 3-way stopcock. You will also need sterile drainage tubing, specimen tubes and a large evacuated container, and a sterile occlusive dressing. Explain the procedure to the patient and obtain written informed consent. You should also verify the patient's identity, mark the correct site, and conduct a pre-procedural timeout. The timeout, which takes place immediately before the procedure is started, consists of confirmation by all members of the care team that the patient's identity, the procedure he or she is to undergo, and the site of the procedure are all correct. You will need an assistant to help position and monitor the patient and assist with the collection of pleural fluid. Place the patient in a sitting position on the edge of the bed with his or her arms resting on a table. The height of the effusion is determined by auscultation and percussion of the posterior chest wall. With a skin marking pen, mark the needle insertion site. The site should be 5 to 10 centimeters lateral to the spine and at least 1 or 2 intercostal spaces below the top of the effusion. The needle should not be inserted below the 9th rib. If available, bedside ultrasonography can be used to help visualize the effusion. In the patient in this video, the pleural effusion is easily visualized, as are the ipsilateral lung and the liver. Prepare the area with antiseptic solution and apply a sterile drape. Using a 25 gauge needle, place a wheel of local anesthetic such as lidocaine along the superior edge of the rib that lies below the selected intercostal space. Switch to a 22 gauge needle and begin to anesthetize the deeper tissues. The inferior surface of the rib must be avoided, since the intercostal vessels and nerve are located in this region. At this point, walk the needle over the superior aspect of the rib, alternately injecting anesthetic and pulling back on the plunger as you advance. Once the needle enters the pleural space, pleural fluid will begin to fill the syringe. Inject more anesthetic at this point to anesthetize the highly sensitive parietal pleura. Note the depth of penetration and then withdraw the needle. If available, a hemostat may be attached to the exposed portion of the needle to mark the depth of the pleural space. Attach an 18-gauge over-the-needle catheter to a syringe and advance it along the superior surface of the rib. Keep pulling back on the plunger as you proceed to the predetermined depth of the pleural space. Once fluid is aspirated, immediately stop advancing the needle and guide the plastic catheter over the needle. When the catheter